Hello there, my name's Damien. I'm a paediatric emergency medicine consultant at the Leicester Royal Infirmary, and I'm going to be talking about some paediatric research challenges and how that interplays with ethics. One of the interesting things about paediatrics is that while you're dealing primarily with the child and young patient, you're also dealing with their parents and or carers. This is a painting from the turn of the century. It's called The Doctor. You have a stereotypical white male with a beard, rubbing his chin sagely, looking at the ill child. And in the background, you can see a man and a woman, the parents of this child, and the woman is in tears on the table. And this painting was done to demonstrate the triumvirate that we have. It's not just about the child, it involves healthcare professionals and parents and carers as well. And sometimes that triumvirate can come in to conflict. It's interesting that we think that we always upheld parent and carer voices. And I think most people would agree that when a child is ill, if they're admitted to hospital, their parents and carers should be with them. But the Platt report, which highlighted this important principle, was only published in 1959. And before that, children who were admitted to hospital and separated from their parents and carers all the time. Those with scarlet fever had to go and be isolated for 10 days, sometimes more. It seems patently absurd to do that now when we look back with a retrospectoscope. And there are some research principles, which I will discuss specifically around deferred consent, which again, I think we're going to have to look and change the way that we do things. And we may change to do more uncomfortable things, but that doesn't necessarily mean it was wrong. Now, this is a slide that if you're a presentation guru, you would say you should never show. So please do use the QR code, and I will share this presentation so that you can all have a copy yourselves to look at the baseline information. But the key reason I'm sharing this is to show that there is a clear difference between research, service evaluation, audit, and public health, including health protection advice. And it's that usual practice that was actually used during COVID to undertake a lot of work that would have been very bureaucratic to have done under normal research principles. But research governance is really important. And it is important that if you do need an ethical review, that takes place. But there is also a lot of research that is just simply service evaluation, and there shouldn't be barriers to doing that where it can provide good amounts of information that can make a difference to patients, in particular children and young people. And we know for a fact that children of different ethnic and cultural minorities are often disadvantaged, and it's through good service evaluation that we've discovered that. So let's look at a great study done in the paper Paediatrics over 10 years, nearly 10 years ago now, 910,000 children visiting a variety of hospitals with appendicitis. And what we find is that Black children are hugely disadvantaged in the prescriptions of opioid analgesics. If we take children with long bone fractures, those in moderate to severe pain, we find a substantial amount do receive analgesic agents, and about half receive opioids. Interestingly, children from minority backgrounds receive analgesics and a 2-point reduction in their pain, but what they are less likely to receive, a bit like the appendicitis paper, is opioids and have an optimal pain reduction. So that the pain score is a bit irrelevant. It has that child's pain being ameliorated. And it's only through studies where we do this big data, this big evaluation, do we find some of those findings. You're not going to get this by just doing lots of studies which require lots of consent. So there is a place for non-consented evaluation. But there is also a place for where you're doing research, where you're testing new methodologies, testing new innovations, that you will need to get consent because this is a research study. Now, why do we need alternatives to prior individual consent? Well, we need to do that in emergency pediatrics because sometimes the illness of the child makes it impossible to get informed consent. If your child is grossly septic, they've got septic shock, perhaps they're about to die, this is not the place to be having a conversation with a parent or carer about whether you should be doing a research study about the amount of fluid that is given to a child. But you do need to be able to do that research. We can't just not do research because we haven't got informed consent. So we're going to discuss deferred consent. There is other strategies such as something called advanced consent or presumed consent, although that's not typically used. There's a waiver of consent, and we do use this in some respects in England at the moment for data analysis, so that families can now consent for their data just to be used, but that wouldn't really be appropriate in a study where you're delivering a new medication, for example. And so at the moment, the only thing that we've really got that and we are using very well is the concept of deferred consent. Now, deferred consent really came into its own in a study called Eclipse. And Eclipse was a study looking at the management of status epilepticus. And this is when you've had a seizure, it's been ongoing and isn't responding to normal medications. And traditionally, what would happen is if you've been fitting for 5 to 10 minutes, you receive a dose of benzodiazepine. If you continue to fit for another 5 to 10 minutes, you'll get some more benzodiazepine. And then if you're still fitting at that point, you'd be traditionally being given phenytoin. You get your phenytoin infusion. And then if you're still fitting, you'd need to be intubated. Now, the problem with phenytoin is that we know it can cause some quite significant side effects. It's difficult to draw up, and it needs to be given over 20 minutes. And so the plan is to compare phenytoin to another medication called levetiracetam, which is also known as Keppra. That's its trade name. And what we needed to know is that after having received a couple of doses of benzodiazepine, which is the best agent to give, phenytoin or levetiracetam, to stop seizures. And the challenge that we've got is, in the same example as I gave for the septic child, if you have a child in front of you who is having an active seizure, it's just not possible to work through the parents, the pros and cons of the study, why we're doing this, what the outcomes are going to be, et cetera, et cetera. And so there was a bit of research done before this study asking parents and professionals how they would feel about a deferred consent approach. So the child would come in, if they get to the stage where they needed to be randomized, that randomized would just occur. And then when the child was well again, someone would sit down with the family and say that the child had been randomized as part of the study, and could we use that data in the study, so that the consent process would occur after the point of randomization. What's interesting about this particular study is that nearly all the parents asked had no problems with it at all. In fact, they congratulated the team and saying, actually, this is a good thing. We didn't want to be asked. And it was mainly the healthcare professionals themselves which were more nervous about this. They didn't want to be having these conversations after the event, but they did recognize the importance of doing this study. And so the Eclipse study went ahead, and it recruited and was a highly successful study in terms of reaching its endpoints. What was interesting is that we all thought that Keppra, levetiracetam, would be the better agent, and in fact, there was equipoise, that the study didn't show a significant difference between the two agents, but it did demonstrate that this form of deferred consent study was possible and was legitimate. Other studies have used it. There's something called the FISH trial, which was looking at the amount of fluids given for children with sepsis. And this is a quote from one of the families, because some study was done within that study about the kind of parental feeling about deferred consent. And nearly by and large, all the family were happy what's happened. There are some parents who do get upset, but they are hugely in the minority. And there is now a wealth of experience and a body of evidence suggests we can do this legitimately. So one of the things to think about is, first of all, does your study need consent to begin with? Is this something that can be done within an evaluation? And then the next question to ask is, will parenting care or providing consent be a burden to them? Can they legitimately be asked in an emergency situation? And if not, then the deferred consent model can be used. I hope that was just a useful introduction, and I'm very happy for my email to be shared to be answered further questions. Many thanks.